It's melody songs.
Iyara TV on YouTube channel. Alabi pe o. Adari Iyara mi o.
Banga.
Alabi pe o. Adari Iyara mi o. Orí adé. Issue and analysis. Àlejò tá bá gbé wá ná máa jóyè gbogbo wa. Shed light on political matters, education and entertainment, fashion and religions, ìmọ̀ tó kún rẹ́rẹ́ on culture and tradition. Àmọ̀tẹ́dùn ara wa pẹ̀lú Adébímpé Adéníran o. Adarí ń bẹ ní ìkàlẹ̀ o. Nóbi ṣeré lọ́sẹ̀ yìí o. Iyara TV on YouTube channel. Adébímpé o. Adarí Iyara mi o. Adébímpé o. Adarí Iyara mi o. Ilé olórí náà rè o. Adébímpé Adéníran aya adarí lónìí tèmi o. Àwùjọ obìnrin, gbogbo obìnrin ó yẹ ká lè mẹ̀tọ́ wa o. Highly educative program ṣe mú un ṣáálẹ̀ fẹ́ máa wò. Adarí mi Iyara dé o. Máa bá ètò rẹ̀ lọ. Adébímpé adarí mi o. Iyara máa bá ètò rẹ̀ lọ. Ẹni bá ní ọmọ àràjò lónìí dé bá tó bá lọ sájò kò kéré ọjà wálé. Iyara mi o. Adébímpé o. Adarí Iyara mi o. Adébímpé o. Adarí Iyara mi o.
It's melody songs.
Iyara TV on YouTube channel. Adébímpé o. Adarí Iyara mi o. Adébímpé o. Adarí Iyara mi o. Orí adé. Issue and analysis. Àlejò tá bá gbé wá ná máa jóyè gbogbo wa. Shed light on political matters, education and entertainment, fashion and religions, ìmọ̀ tó kún rẹ́rẹ́ on culture and tradition. Àmọ̀tẹ́dùn ara wa pẹ̀lú Adébímpé Adéníran o. Adarí ń bẹ ní ìkàlẹ̀ o. Nóbi ṣeré lọ́sẹ̀ yìí o. Iyara TV on YouTube channel. Adébímpé o. Adarí Iyara mi o. Adébímpé o. Adarí Iyara mi o. Ilé olórí náà rè o. Adébímpé Adéníran aya adarí lónìí tèmi o. Àwùjọ obìnrin, gbogbo obìnrin ó yẹ ká lè mẹ̀tọ́ wa o. Highly educative program ṣe mú un ṣáálẹ̀ fẹ́ máa wò. Adarí mi Iyara dé o. Máa bá ètò rẹ̀ lọ. Adébímpé adarí mi o. Iyara máa bá ètò rẹ̀ lọ. Ẹni bá ní ọmọ àràjò lónìí dé bá tó bá lọ sájò kò kéré ọjà wálé. Iyara mi o. Adébímpé o.
Yeah, you're welcome to another interesting edition of Issues and Analysis. And this is another week of an health talk. Ètò ìlera òun náà ni a fi ọ̀sẹ̀ bíi méjì sọ. My name is Adebimpe Adeniran Adonri Iyara bí gbogbo ayé ṣe mọ̀ mí sí. Today, as we've been expecting, we're having a doctor in the house to talk about something that is really bothering our men. Nǹkan tó jẹ́ pé kò ṣeé fọwọ́rọ́ sẹ́yìn, pàápàá jùlọ ní ọ̀dọ̀ àwọn ọkùnrin wa gbogbo jákèjádò àgbáyé dẹ̀ ni prostate cancer. And I already have in the studio Dr. Taiwo Alabi. Dr. Taiwo Alabi is a fellow of the Medical College of Surgeons in Urology. He is the recipient of the prestigious Samanwa Award of the Best Candidate in the Faculty of Surgery of the National Postgraduate Medical College of Nigeria, 2016. Profile one is very intimidating and awesome. He has more than 14 publications to his name in both local and international journals. Dr. Alabi, you're welcome to the program.
Thank you, ma.
Ṣàlàáfíà ni o, a kú dédé àsìkò. A kú gbogbo ẹ̀yin náà NSAS lọ́dọ̀ yín.
Ẹ wo kódà ó ga díẹ̀.
Ó kọjá NSAS o.
Díẹ̀.
Ẹ jẹ́ káwọn èèyàn túmọ̀ yín lé, just talk briefly about yourself for a few seconds. Yeah.
Yes, Taiwo Opeyemi Alabi. I'm a consultant urologist. As she has introduced me, I'm a fellow of the Medical College of Surgeons, specialization in urology. So I'm a consultant urologist at Federal Medical Center in Putemeta, Lagos. And my main area of specialty is endourology, that is the treatment of urological problem.
Okay.
By going through the natural orifices. It means is that gbogbo àìsàn tó ń bá tó jọmọ́ kidney, ureter, bladder, prostate, orúnkún, then ẹpọ̀n gan fún rẹ̀. So gbogbo àìsàn tó jọmọ́ èmi máa ń ṣe ìtọ́jú. Mo máa ń ṣètọ́jú ẹ̀ láì lo abẹ. So that is, I go through the natural orifices.
Wow.
To enter all those tiny area and then use laser and other technology to treat urological problems.
That's great. So today we are treating prostate cancer.
Yes.
What is prostate fúnra ẹ̀ gan ká tẹ̀ tó máa lọ síbi tí cancer ti wá?
Yes, Cherry prostate òun ni a máa ń pè ní àwọn Yorùbá máa ń pè ní ẹpọ̀n inú.
Ẹpọ̀n inú.
Ẹpọ̀n inú. For men, there is ẹpọ̀n tó wà níta. Then nínú, there is ẹpọ̀n tó wà nínú. Ẹpọ̀n yẹn wà níbi odò abẹ́.
Okay.
It's below the bladder.
Okay.
So, this picture.
Okay. Aha.
Look at this.
Yeah.
This organ is the bladder. Okay. So it's like I get bladder in one go nowhere. So this is the bladder.
Okay.
So bladder nísàlẹ̀ òní prostate wà ẹran yìí.
Oh.
Àwọn méjì yìí òun là ń pè ní ẹran yẹn là ń pè ní prostate.
Okay.
So now ṣé rí ibi tí mo kùn tó dúdú yẹn ibẹ̀ gangan ni cancer ti máa ń develop. Prostate yìí is like a chestnut. It's like a chestnut organ. If you look at it, it looks like a chestnut.
Okay.
This organ you are seeing below the bladder. So the pipe that carries urine from the bladder passes through the center of it.
Okay.
This is the pipe. You can see the pipe.
Then.
This pipe. This pipe. Passing through the center. So, prostate yẹn ó ní awẹ́ méjì. Ẹ máa rí bí awẹ́ kan lápá ọ̀tún. Awẹ́ kan lápá òsì. So it has two. Let me explain it in a way that will be simple and easier to
layman, yeah,
by my viewers. So let me just say it has two lobes.
Okay.
And we know that anatomically it's more than that. Let me just say it has two lobes, the right and the left. And you can see that pipe that carries urine from the bladder passing through it. Okay? So ẹran yẹn là ń pè ní prostate.
Prostate.
It's below the bladder. If you look at it, it looks like an apple.
Okay.
If I think a slice apple. Right. So I'm going to apá kan àtàpá kejì.
Apá kejì bẹ́ẹ̀ aláwẹ́ àwẹ́ méjì.
So àárín apple yẹn bí pé òun là ń wò yìí.
Okay.
Now, so that gives you an idea of what the prostate is, its location in the body, and how it relates to the bladder, which is very important. And this will give you an idea of the problem that can ensue from the pathology of the prostate. Okay? So, having said that, we know what the prostate is, we know the location. So the cancer of the prostate. Cancer generally means an abnormal growth.
Okay.
Okay? It's like abnormal growth of the normal tissue in the body. A tissue, a cell within the body will just start growing at an uncontrollable rate. One cell will just become mad, like it will go away from the influence of the control of the body. Normal influence that regulates the growth. So that's what cancer is. So when it arises from one of the cells in the prostate, call it cancer of the prostate.
Wow.
Okay. So now, what happens when there is cancer of the prostate? Or probably let me tell you
the causes
that can cause cancer of the prostate.
Yeah.
So that will interest my viewers.
Okay.
The main cause. Okay, let me start by saying that the cause is generally unknown. What makes some men to have it and other men not to have it cannot be explained. Okay, that is poorly understood. But what we know scientifically is that prostate cancer occurs in men that have testes. Once you have testes and your testis is producing testosterone, you can have cancer of the prostate. That is the major, and this has been proven because in eunuchs, men that were castrated from childhood, they don't develop cancer of the prostate.
But
Because don't produce testosterone. Because testosterone produced by the testes in every man is what makes the both internal and external sexual organs of the man to grow. Okay? And one of these organs is the prostate. So it is this same organ that makes one of the cells from the prostate to suddenly run mad and starts growing abnormally. So once you have testis, a functioning testis producing testosterone, then you can have prostate cancer.
Wow.
So that is what means. Okay, so how be it there are factors
Okay.
that have been shown to be like predisposing factors to people having prostate cancer. Okay, we have established that every man that has testes that is functioning, that is producing testosterone, can have prostate cancer. Okay, now what can make some men predisposed to it and others not predisposed to it is some of the factors could be smoking.
Smoking.
Smoking is implicated in most diseases in the body.
Oh, yeah.
Okay? Intake of fats,
Okay.
excessive intake of fatty diet,
Fatty diets.
and smoking, excessive intake of fatty diet. There is a factor which before people used to think is associated with prostate cancer, which has been debunked. That is vasectomy. Okay? Vasectomy is when men try to cut their vas with the view to preventing them being pregnant women.
Okay.
That has been proven not to be a predisposing factor.
Okay.
Okay, because many people still erroneously believe that. But after all said and done, some people have also said deficiency of antioxidants like vitamin E, vitamin A, and all that could be predisposing factors. Okay, but generally speaking, all those are just risk factors. The main thing about prostate cancer is once you have a functioning testis and it's producing testosterone, you are at the risk. And it's also found that as men age, the risk of them having prostate cancer increases.
Wow.
That's why it's commoner in older men.
Yeah. Okay.
Older men. And this brings me to the point that every man, once you are above 40 years,
Okay.
you annually check your PSA, prostate specific antigen.
Okay.
This is what is produced by the prostate. It's a hormone that is produced by the prostate and it is secreted into the blood. So when it is measured, it can give an idea of whether the prostatic growth or enlargement is due to a benign cause, that is a non-cancerous cause, or due to prostate cancer. So we have talked about the predisposing factors, the risk factors for developing prostate cancer. So radiation could be is one of the factors, which is common to most cancers. When people get exposed to radiations, they can come down with cancers, not only prostate cancers, cancer alone.
Okay.
So if somebody has prostate cancer, how is he going to know?
Like symptoms and signs.
Symptoms and signs. How is he going to know? Like I showed you, if you look at this diagram again, okay, look at the location of the shaded line, the shaded part of the prostate. That is where prostate cancer grows. Okay, so that will give you an idea of the issues with prostate cancer. It is a very silent cancer.
Wow.
You don't know they have it until it starts to wreak havoc. It starts to wreak havoc until it starts. In fact, many people will know for the first time that they have prostate cancer by metastatic symptoms. in our environment. I've attended to hundreds or possible thousands of patients with prostate cancer. And in this environment, because of lack of awareness, and even in advanced setting, many patients will come, they will just suddenly discover that they are not able to lift their legs. They are not able to walk again, their legs are weak. And be wondering, they will think, somebody will say, he stepped on something. By the time they come to the hospital, we'll see, we'll review, and then the PSA, by the time we do the PSA, I've seen a patient that had 12,000 nanograms.
Wow.
The value of that PSA is supposed to be less than 4, 0 to 4. This patient had 12,000. At this level, what it means is that the prostate cancer has spread to almost every bones in his body.
Everywhere.
Yes. So I'm trying to give you an idea of the symptomatology of prostate cancer. What the takeaway is that many people will not have symptoms at the early stage of prostate cancer. Many patients will not have symptoms. They won't even know they had it. Okay? Because of the location. So those that have symptoms, the symptoms they might have include difficulty with passing urine. The difficulty passing urine, which might include straining. That is, when they go to pee, they have to press their abdomen to be able to press the bladder to push out urine. So they strain. Okay. Then they discover that the stream of their urine, rather than being jet-like, projectile, jet-like, it becomes weak. It comes like when, for those of us in Nigeria, in developing countries, when waterworks, they are taking their, when they are out, it won't flow very well. The stream will be poor. Okay. Then they will frequent the loo. They have to go often. Some people, some patients go every 15 minutes. Ideally, you should be able, once you finish peeing, you shouldn't have the urge to go again until about minimum 3 hours later. So, but many of them, they go frequently. And after about toton, after they have finished peeing, they still feel like there's some urine in their bladder that they are not able to completely expel. So that is what we call feeling of incomplete emptying of the bladder. Okay, so and then some of them, they can see blood in their urine. So, and I must say that, I must emphasize that bleeding, blood in urine is a red flag sign.
Wow.
I've encountered people that misconstrue it for signs of maturity. Okay, when you see blood in your urine, it's red flag.
Red flag.
For malignancy. Once you see blood in your urine, you must present to the hospital. Go to the hospital. Once you see blood in your urine. Okay, so patients with cancer of the prostate can have blood in their urine. Okay, so then some of them, they will wake up frequently at night to also pass urine. Some of them have what we call urgency. Urgency is a compelling urge to pass urine that cannot be delayed. More often than not, if you have the urge to pass urine, you can delay it until you get to a convenient location.
Then,
But in people with cancer of the prostate or generally disease of the prostate, they cannot defer urination. It has to be now. So that's why we call it urgency. Then some of them can have what we call urgency incontinence. They have urgency incontinence. What it means is that they have the urge to urine, to micturate, to pass urine. The man is rushing to the loo.
yeah.
He has urgency, but he has a compelling urge to pass urine, and he's rushing. Before he gets to the loo, he has peed on himself.
Yeah.
Called urgency incontinence. So all this can occur in patients with prostate cancer, but can also occur in patients with benign, that is non-cancerous diseases of the prostate.
Oh, okay.
So the take home is that before prostate cancer begins to give symptoms,
Okay.
it's getting to an advanced stage. It's already at an advanced stage. Okay.
So,
Sadly, when it is at early stage, it does not have symptoms. I have patients that came to me for something different.
different.
But based on their age, I screened them for prostate cancer. And I found out that their PSA was high. We did their biopsy, they had prostate cancer. And they did not have any of the symptoms that I earlier stated. So this is to emphasize the point that prostate cancer at the early stage is asymptomatic. Patient isn't going to have a single symptom.
Wow. Oh.
Now,
So
what it means is
okay. Go ahead, sir.
what it means is that any man that has a functioning testis, producing testosterone that is above 40 years must do annual screening of prostate specific antigen. Prostate specific antigen. As a matter of fact, there are 3 tools we use to screen men for prostate. We use what we call prostate specific antigen, which is a hormone produced by the prostate that is secreted into the blood.
Okay.
The normal value is less than 4, 0 to 4. If it's more than 4, then you have to rule out prostate cancer. It doesn't always mean that it is due to prostate cancer, but when it's more than 4, you have to exclude prostate cancer. Okay. So that is one. The other screening modality is what we call digital rectal examination. Is when a clinician sticks out the gloved index finger into the patient's anus to feel the prostate. When you use this, when we feel the prostate, by our training, we know how a cancerous prostate feels, different from a benign prostate. But because, like I told you, the location of the cancer of the prostate is peripheral. So sometimes at the early stage, the finger might not be able to detect it accurately. So that brings me to the third modality of detection, that is transrectal ultrasound scan. That is when you insert an ultrasound probe through the anus to scan the prostate. Okay, this gives us the echo texture of the prostate. And based on that, in experienced hands, you can be able to differentiate a benign prostate from a cancerous. So we more often than not use combination of these three modalities to screen an average patient that comes to the hospital for prostatic problem. Okay, so that's how we screen the patient. Okay. Anybody above 40 years should be screened annually.
Okay.
Annually for cancer of the prostate. More often than not, before now, let me say before now, prostate cancer occurs majorly in elderly. In elderly, in the 7th decade of life, 65 and all. Now, there's a trend that we're seeing of younger people, younger males coming down with prostate cancer.
Wow.
And they come down with prostate cancers, they come down with a very aggressive prostate cancer that kills them within a few years of diagnosis.
What are the causes of this? Smoking, or do we say sexual activities impact the risk of the cancer?
Yes, you see, these are things that people have studied, but nobody has been able to substantiate them. They are more often than not anecdotal in their in the weight of the evidence they carry. They're more or less like circumstantial. Okay.
Okay.
Sexual exposure and prostate cancer, they are not related at all.
Okay.
So, but you see this trend that we are seeing with prostate cancer is not limited to prostate cancer alone. Most cancers nowadays, we are seeing them at earlier ages. Okay? The same thing with breast cancer.
Yeah.
So my colleagues, mastologists, they will tell you that they are now beginning to see prostate breast cancer at earlier ages now. Okay. Different things, different reasons. People have alluded to different reasons: global warming, destruction of ozone layers,
diets, even diets,
modifications, westernization of different. So yes, but you see, I'm telling you what we see on the field. Okay, in the past 2 or 3 years, I've lost people in peri 40 years. About 4 of them. So prostate cancer. In fact, there was this devastating one, a 38-year-old man that came. We did this PSA, he had prostate, we did biopsy, he had prostate cancer. There was one that was 42, another one that was 45.
Wow.
So what it means is that once you are from 40 years and above, you must do your PSA annually.
Is the test free? Is it free?
It's not free. It's not free, but in Lagos here, I think it's about 5,000 naira.
That's still affordable.
5,000 naira.
Okay. Do you think there's enough awareness for men to do the test?
Yes, I would say that the awareness is low.
Very low.
That accounts for the pattern of the presentation we're seeing. Most patients present at late stage, advanced stage, when the disease has taken over their body, that there's little or nothing we can do to stage them. So that is what we see in our environment. So this speaks to the fact that we need increased awareness. People need to know, and more often than not, people need to measure their PSA annually once you're above 40. If that's the only thing my viewers take away from this broadcast,
Yeah.
I think my work is done.
Yeah.
Because other things we're going to talk about, not be very familiar with them. Okay, it might actually be like overkill. Okay, of the disease. So I've said it that when a patient comes to the hospital and he has elevated PSA without symptoms, the next thing is we're going to do prostate biopsy. And what does biopsy mean? Biopsy is we go to the organ, what we usually do here in Lagos is we do ultrasound guided biopsy or MRI fusion guided biopsy of the prostate. That we a combination of the ultrasound and MRI to guide or to localize the focus or foci of the cancer within the prostate. Then we use the needle to take specimen, to take sample from that area, and we send it to
The lab.
lab for histopathological analysis. So that's what we do. So if that tells us that is cancer, then we would proceed with the treatment. Because the mainstay of the diagnosis, the gold standard is MRI fusion guided biopsy of the prostate. Where that is not available, ultrasound guided is done.
Okay.
Where that is not available, digitally guided, that is the surgeon just sticks the gloved index finger into the anus and then uses to guide a needle to a suspicious area and takes a specimen from there and sends it for histology. So once we diagnose prostate cancer, the next thing is to stage. How do we stage? We want to know whether the prostate, the cancer is within the prostate,
Okay.
or it has spread out of the prostate. When it is within the prostate, it's curable.
Okay. When it's outside?
When it has spread out of the prostate, then it's incurable.
Wow. That means the person will die.
It's a matter of time. It's a matter of time the person will die. So the goal is to pick it when it is within the prostate. When the cancer is within the prostate, then you can actually remove the prostate itself with the cancer within it, and then the patient stands the chance of being cured.
After the cure, can the patient live a normal life as a man?
Yes, yes, yes and no. Yes and no. I'll tell you why. Because you see, when the prostate is located, like I told you, below the bladder.
Yeah.
Okay. Imagine if you have to remove this prostate now. You have to remove it. When you remove it, what it means is that you now have to join the bladder to this urethra.
Okay.
You have to join the bladder to this place. So this organ that is between it, this prostate is removed. So you have to join this urethra straight to the bladder. And that comes with its own attending problem.
Oh my God.
The three major problems that happens are: one, the patient can have what we call urinary incontinence. You may not be able to control the urine. Although with advancement in technology and the use of robots, this risk is reduced, but it still happens. Many patients, after we call it radical prostatectomy, radical prostatectomy, that is, you completely remove the prostate with the seminal vesicle, you remove it, and you dissect the lymph nodes that's drain the prostate. You remove them together, everything. You throw away them. So by the time you do that, you stand the chance of curing the patient, and many of them who come with early stage disease actually get cured. Okay, so but it comes with attendant complication. One of them is incontinence. Many of them will recover from the incontinence in about 18 months to 2 years after the surgery. They'll be able to control their urine on their own.
Okay.
Then the other complication is erectile dysfunction. Yes.
I will learn.
The reason being that the nerves that supply the penis that makes a man to have erection passes beside and behind, slightly behind the prostate. So by the time you are trying to remove it as a surgeon, you're trying to remove it, you can stretch the nerves. And that can cause temporary loss of function for the nerves. So that they might not, but you see all this, there is a lot of advancement in science for the treatment of all this. If a man has erectile dysfunction, there are a whole world of treatment we can offer that man.
In Nigeria?
Yes.
Okay.
In Nigeria, we can offer them vacuum pump, we can offer them silicone. There are medications that can be given to such men. Okay, so the complications that come from the treatment of the radical treatment of the prostate, they have treatment. Incontinence, there are treatments, there are surgical and non-surgical treatment for the treatment of incontinence that are very effective. And as a matter of fact, a properly and well done radical removal of the prostate, you understand, rarely comes down, with incontinence. And if they do, many of the patients will recover over 18 months or thereabout. They will gain full control of the. Why they are expecting to resume to have good control of their urine, they can use pad and all that. So the third complication is narrowing. From the point at which you join the, like I did the other time.
Okay.
The point where you join you see?
Yeah.
When you remove this prostate this way, when you remove it, you have to join the urethra here to the bladder. The point of joining.
Artery.
Yes, that could be narrowing. Okay. But let me tell you, all these three major complications can be treated effectively and successfully. Okay? And they are nothing compared to the problem an advanced
stage
metastatic prostate cancer can cause patients.
Okay.
Patients who are completely messed up by metastatic prostate cancer. It has predilection for spread to the spine.
Wow.
It's to the back. And what it does is that it compresses the spine. It damages the bone, and that bone, once the bone, which is the support of the spine, is damaged, the spine collapses and it damages the vertebrae, they collapse and damages the spinal cord.
Wow.
patient becomes paraplegic, they cannot walk. Many people come to the clinic on wheelchair. So what is incontinence compared to paraplegia?
Yeah.
What is erectile dysfunction, which can be compared to paraplegia? And also, an advanced prostate cancer can spread to the long bones, the bones of the thigh. I've seen patients come to the hospital with fracture, unexplainable fracture. It just slips a little bit, and then the bone breaks like biscuits. The bone has been riddled.
Wow.
The cancer. So it can break easily. So these are the ways patients with advanced disease of the prostate can present. Okay? It can spread to the brain. There have been reports of prostate cancer spreading to the retina and causing blindness in patients.
Really?
Spread to the ribs. Can spread to the ribs and can damage the ribs. It can spread to the pleura, that is the lining of the inside of the lungs, of the outside of the lungs, the chest, the inside of the chest. That space. It can spread there, cause fluid accumulation in the chest. So it's it rarely spreads to the liver, but it can. It rarely spreads to the liver. So the anaplastic type can spread to the liver. It spreads to the bones and completely damages the mudumudu will produce the blood cells. Will renew blood wa.
Yes,
cancer replace the mudumudu. So that in place mudumudu I can repair white is pale. So to bat in the rare. So and at that stage it becomes it's just a matter of time. The patient yes. So the take home is that the prostate cancer should be picked when it is
at early stage.
When it is localized, when it is at the early stage, that's when it's advisable to pick it. When it is picked at that stage, it can be cured. And what I also tell people is that prostate cancer is one of these slow-growing cancers in the body. In fact, is kind of lazy. It's a lazy prostate. It's a lazy cancer. Because the thing is, before it becomes symptomatic, it must have stayed for like 4, 5, even 6 years. And that is why it gives you enough room
to check up,
and to treat it. Okay? It is very rarely, it is when you encounter the aggressive type. And I want to use this opportunity to state that the prostate cancer in blacks is usually very aggressive.
Why? Same thing with cardiac arrest we discussed last week. Why always?
Yes. Because let me also tell you, I don't know, but you see, it has been found out that the prostate cancer in blacks is usually more aggressive. It can be, maybe we elaborate testosterone. I don't know, maybe. And also, like I tell many of my patients, you see, when we do operations on prostate too, our own our prostates are usually even bigger. We encounter very, very big prostates in this environment. very big prostate. An average prostate in this environment is big. Okay? And also, when you want to do your surgery on the prostate, you also encounter big phallus in this environment. When I say phallus, I mean penis. Because you have to go through, we go through the hole through the penis before we get to the prostate.
So what I
So
told you?
a big penis could be an hindrance to getting to the prostate safely.
Wow.
Okay. I've discovered this in an environment: big penis, big prostate, then aggressive cancers.
So bad.
So that is the picture in the environment. So the message is we need to be more aggressive with education, with awareness, so that people can know that once you're above 40 years, you need to get annual screening for prostate cancer.
Yeah.
You need to do that. But if you have it, it can be picked early, and appropriate treatment can be done.
Yeah.
Okay? So that is what we need to emphasize.
So,
That all the time.
Doctor, can we just use this opportunity to tell our people back home where they can get the test done? And do you have a platform where the awareness can be created for people, for men over 40? Because as you say now, only for like 6 years, that's give them enough time to get tested.
Yes. Yes.
So where are the centers that if they can be tested?
Yes, I think generally people can get tested. I think the test is readily available in all the labs. I can say that.
Okay.
Most cities in Nigeria, most cities, they have labs that are well equipped to do test, prostate specific antigen. So, and then the reason we also need to, and in addition, not just do prostate specific antigen, get to see, request to see a urologist.
A urologist, okay.
I've also seen cases where the prostate specific antigen is normal and the patient has prostate cancer.
Imagine. Wow. So what went wrong?
Yes, I'll tell you. There's a segment, there's an entity called non-PSA secreting prostate cancer.
Wow.
Non-PSA secreting prostate cancer. What this means is that this entity, the patient has prostate cancer, but is the type of cancer that is not secreting PSA. Okay? Because you know that when you have malignancy of the prostate, there should be corresponding rise in PSA. But these people have cancer of the prostate, but they don't elaborate. And that is why it's important to see a urologist. Okay? See your urologist. Once you're above 40, get to see your urologist once in a year or thereabout. Just get to see your urologist. Let him request for PSA. Let him do ultrasound. Let him stick his finger into your anus to feel your prostate. In this patient, and that's why we use the combination of these three tests: the PSA, the ultrasound, and the digital rectal exam. you know, determine whether a patient has prostate cancer or not. Okay, one is none of them is foolproof. None of them. You have to combine the three of them sometimes to be able to arrive at a very important decision. Okay.
Yeah.
So it's available in all labs, all over Lagos, all over main cities in Nigeria.
Okay.
So you can get to do PSA, and there are urologists in all states of the Federation of Nigeria.
In all government hospitals?
All cities, at least there will be a major government hospital in every major town that has a urologist.
Okay.
Okay, so just get to see your urologist and then you'll be counseled appropriately.
Yeah, thank you very much. So on a lighter note, before I lose you, Dr. Taiwo Alabi, healthcare facilities generally in Nigeria, how do you see it?
Yes, we are not where we should be, but it's not bad as people abroad think it is.
Some people abroad.
Yes, because let me tell you, I have had several encounters. Okay, we have a patient, we already offering the patient the best.
Okay.
Somebody is already calling in from US. He's asking you questions. He's trying to second guess what you're doing.
Mm-hmm.
And here I am trying to offer the patient the standard of care. There is what we call standard of care.
Okay.
That is the best that the patient will be offered anywhere in the world. Okay, so that is evidence-based. And here somebody is trying to breathe down my neck and try to second guess what I'm doing. So it's not as bad as many of the people abroad think it is. Okay, we are not where we should.
Our leaders fly out to take care of themselves. If you as a doctor is talking this way, many of our leaders fly out to take care of themselves.
Yes, you see, which is highly regrettable. Mm-hmm. It's highly regrettable. Highly regrettable. Because you see, most of the things that people go outside for, they are available in Nigeria.
And affordable.
And let me tell you something. For the first time during this pandemic, many people were forced to look inwards.
Mm-hmm.
Yes, place was locked or completely locked down. They couldn't travel. They had to look inwards. And for the very first time, many of them were discovering that there is a lot of proficiency, there's a lot of resources within the country to solve the health problems.
Uh-huh.
Yeah. And I tell you, during this pandemic, I've operated people that in my lifetime, I would not have thought I would ever have any reason to even cross their path.
Wow.
During this pandemic. Okay, and that speaks to the fact that there's a lot of capacity in the country that are left untapped, unharnessed, and also people more often than not decide to focus on the negative side rather than emphasize the positive side.
Are you with a government hospital, Dr. Alabi?
Yes, I work in government hospital, but I moonlight in top private hospitals around Lagos.
Oh, okay. Because I have the opportunity of talking to some doctors back home. They said they are being owed salaries. Their salaries are not enough to take them home. And many people are talking about the brain drain. I know brain drain doesn't start from this regime. It's been on for a very long time. medical personnel going abroad for greener pasture. So, what advice will you give the government regarding this?
Yes, you see, I think the government has to create enabling environment for Nigerian doctors to function.
Yeah.
You see, as we speak, UK, they are expanding the NHIS, employing more doctors. And who are these doctors? They are doctors from Africa,
Yeah.
from India, from you understand, from Asia. Okay? And let me tell you, some of the best minds world over are Nigerians, doctors, surgeons, skilled surgeons, fine surgeons.
Yeah.
Okay? So what I would advise the government is to create enabling environment for Nigerians to use their ingenuity to profit Nigerians rather than take those things abroad to profit other countries. You understand? The remuneration should be, they should improve the remuneration. You see, I used to tell, I was discussing with some people. I said, when people like us, when we were growing up, we used to see doctors, I used to see doctors as highly respected people, you understand?
Yeah.
Respected. Then doctors lived in quarters. They are private, they have apartments. And every doctor is like a judge.
Yeah.
You don't want to stand in front of a judge that is hungry.
Oh.
It's not to pervert justice. The same with doctors. You want to be treated by a surgeon that is hungry and angry. So, and ordinarily, doctors should not bother about where to live. I'm telling you, doctors should have quarters within the hospital where they live. There should be staff school within the environment that doctors, so that their children, the schooling of their children is not something they have to bother themselves about. Okay? These are the things that the government, that government used to provide. There are doctors' quarters, you understand? There are staff school within the hospital. Big hospitals, they have staff school where doctors' children go to. The pay is also decent, and they can afford basic things of life. You don't have to be rich, but you don't have to be bothered by the basic mundane things of life, so that you are not able to focus on the things that matters, which is saving lives.
Yeah.
These are issues.
The very complicated.
These are things that the Indian government should look into.
Thank you very much.
And also regular training for doctors, overseas training, and all that. Overseas training, it should be mandatory. Because you see, many of the things that I do now, they are things I acquired moving around the world. I've had the opportunity to interrogate, to work with the best minds around the world. In my specialty, in endourology, I've had opportunity to interact with them, ask them questions, see them operate, see how they practically, solve problems. So, and these are things that has helped me tremendously.
You've been to how many countries now, doctor?
Maybe a few. You see it, you see my profile. Been to the US, I've been to Morocco, I've been to Istanbul, I've been to Slovenia,
India, Turkey.
India severally.
Okay.
So you see, you keep moving around the world, you keep learning from the best, you keep digging, grinding, it's all with a view to,
who bankrolled your trips? Who bankrolled your trips?
God. you see, one thing, you see, let me say this. You see, necessity is the mother of invention. You see, my first trip abroad to India, I sold my car. You see, as at that time, many of my colleagues, they had lands, they were building, they had their property that they were building. They were riding good cars.
Wow.
As at that time, I didn't have land. At that time, I sold my car. So to be able to travel abroad, because I know that there are some things, once you get it, every other things
will follow.
You know, are settled. Yeah. Okay. So nowadays, is it, you know, at the moment, many people, you know, want you to operate their relatives and get calls all over Nigeria, even outside the country. People want me to treat their relatives. It is by the mercy of God and by it's a product of years of grinding, years of laboring, learning, relearning, talking to the best, learning from the best, and then, you know, sacrifice. So it's what it is. And let me tell you, I'm not the only one doing this. Many doctors in Nigeria do this. People bend over backward. I have a lot of colleagues who are doing things like this. We use hard-earned money to sponsor ourselves, to learn across the world, okay, so that we can deliver the best.
Yeah.
Okay. So, and that's why I tell people only see the negative in Nigeria. They're not emphasizing the positive. A lot of people, a lot of Nigerians within the shores of Nigeria, they are doing very well. I have friends in neurosurgery, do surgery to the nose, to the mouth. You understand? They do all sorts of, you know, magical things. And the patient have very outstanding result that is comparable to what people get
anywhere in the world.
So, and we all like this, like we are doing, you know, they bend over backwards, sell properties, sell different things to sell abroad for training. So it is what it is. So
that's very good. Thank you very much, Dr. Taiwo Alabi. It's very nice having you on the program, and I'm very sure if can we have your number? Can you give people your number so that especially our many people maybe I don't know about the value of
yes, what I would do is
contact,
you can follow me I'm on social media.
Okay, good.
Easier that way. I'm on social media. My IG Instagram handle is iEnd Urology at iEnd Urology. Let me just write it.
iEnd.
HIGH.
Okay.
END. Urology.
Okay. Okay.
iEnd.
Urology. Okay.
HIGH. iEnd. Urology.
Urology.
So at iEnd Urology. It's the same for Twitter, YouTube, IG, and Facebook.
Okay.
Okay. You can follow me. I post videos of my procedures.
Yeah.
Those of and very often I educate people about common urological problems and how to, you know, handle them. So you can follow me on these various media. You can private chat me, you can DM me, and as much as my busy schedule will allow, I will reply.
iEnd Urology.
Yes, iEnd Urology at iEnd Urology. Excellent, excellent, excellent.
Okay.
So the same for YouTube, Twitter, IG, and all that. Facebook.
Because many people, even this prostate cancer issue, many people back home are just when things comes to the issue of private part in men and women, our mentality back home is like, me, if I can't go. Do you understand what I'm saying? People keep this to themselves. It is come kọjá level pé màá wá lọ sọ fún doctor pé báwo ni doctor yìí máa wo ojú ara mi pé nǹkan ń ṣe mí. So that is why I said maybe some people will need to talk to you, get in touch with you one-on-one. Àwọn tó bá ń wò wá báyìí. So wọ́n lè wá bá yín tẹ́bájọ fún wọn appointment, because people take all these things like màmá lu àgbòsí tíyanu á fi ṣẹlẹ̀, which is very wrong.
Very wrong.
Very wrong.
Very wrong. Many of them will come back in a very bad state. At which time there will be nothing to
do
again.
It will just be a matter of time.
Yes.
Wow. Thank you very much, Dr. Taiwo Alabi. It's nice having you on the program. So,
Most definitely.
This is very educative and interesting. Thank you very much. God bless you, sir. Bye.
Bye.
Thank you. Bye. Yeah, thank you. So that was Dr. Taiwo Alabi on prostate cancer. Ẹ ká gbìyànjú ká bá wọn sọ̀rọ̀ wọ́n kẹ́ lọ sí hospital tó bá wà tó sì fún test. Let's meet again next week. Thank you.
It's Melody Songs. It's Melody Songs. It's Melody Songs.
Iyara TV on YouTube channel. Alabi Umpe o. Adari Iyara mi o.
Banga.
Alabi Umpe o. Adari Iyara mi o. Orí adé. Issue and analysis. Àlejò tá bá gbé wá. Shed light on political matters, education and entertainment, fashion and religions, ìmọ̀ tó kún rẹ́rẹ́ on culture and tradition. Àmọ̀tẹ́dùn ara wa pẹ̀lú Adébímpé Adéníran o. Iyara TV on YouTube channel. Alabi Umpe o. Adari Iyara mi o. Alabi Umpe o. Adari Iyara mi o. Ilé olórí náà rè o. Adébímpé Adéníran aya Adari lónìí tèmi o. Àwùjọ obìnrin, gbogbo obìnrin ó yẹ ká lè mẹ̀tọ́ wa o. Highly educative program ṣe mú ṣáàlẹ̀ fẹ́ máa wò. Adarí mi ìyá àràdé o. Máa bá ètò rẹ̀ lọ. Adébímpé adarí mi o. Ẹni bá ní ọmọ àràjò lónìí dé bá tó bá lọ sájò kò kéré ọjà wálé Iyara mi o. Alabi Umpe o.